And now welcome Deborah Kobylt.
Thanks so much, Kurt, for that introduction. And thanks everybody for joining us for Deborah Kobylt Live. On the phone with us, we've got Dr. Robert Winters, infectious disease specialist over at Providence St. John and UCLA Santa Monica. Thank you very much, Doctor, for joining us.
And good afternoon.
Yeah, thank you. So why don't you give us some of the latest of what is going on? What is the scene there of what's going on over at both at Providence St. John and also at UCLA? Have you been overwhelmed there with COVID patients, or are you able to handle the amount of patients coming into those hospitals?
Right. Well, I'm not a spokesman for either hospital, but I can tell you, as I've been at both facilities, they are managing a fair number of COVID-19 patients. The ICUs are full, but there's regular patients in there that are not COVID patients because obviously life goes on with heart attacks and strokes and other problems. But I think we're doing a very good job managing the current patient flow.
You talked a little bit briefly earlier to me about viral load. Can you explain to me what is viral load and to everyone else out there? And it has to do with when one is just infected with the coronavirus, right?
Right. Viral load allows doctors and scientists to talk about actually how much virus is present. So individual viral particles, we call them virions. And we can determine how much virus, assign a number to it, how much virus is present in any one individual per unit of tissue that we're looking at. And so what we've learned about corona-19 virus is that the initial infection, the first few days where people become symptomatic, they have extremely high viral loads. The immune system has not recognized the virus, has never seen it before, so the viral reproduction essentially goes unchecked. And then we can watch the normal evolution where that viral load number reaches a very high level in the first few days, maybe the first week after initial appearance of the illness. And then it begins to go down as the immune system recognizes this virus. You start forming antibody. And then typically, as you start developing antibody levels that are high enough to attack the viral load essentially goes away, goes down to zero as the antibody levels come up. And that's a normal type of infection where people get infected, they're ill, and then they get better. But what happens in people that ultimately die from this infection, their viral loads do not go down, but they remain elevated and they tend to go even higher. That obviously represents a bigger problem because the higher the viral load, the more virus that's present, it becomes a more complicated infection. And obviously, as there's more virus present, it starts becoming what we call a lower respiratory infection. And as you get the lower part of your lungs involved, what we call pneumonia, that starts triggering this very, very severe inflammatory response. And then ultimately, people who don't survive this infection, it's not that they actually die from the virus. They die from the inflammatory response that this virus creates, and they die from what's called adult respiratory distress syndrome, or ARDS for short.
What do you do if you're a person who has inflammation, who has asthma? I mean, that's kind of a scary thing. I mean, people that I know who have these issues are staying clear of most people and taking this very seriously, but it's still hard to do. You've got to go get your groceries. You live in a community or a home with people that may or may not still be coming in and out. Are they very susceptible? Not necessarily if they're older, but if they have those conditions.
Well, clearly we know there are risk groups for people that may have more severe disease or be at higher risk for dying from it. And clearly those individuals with underlying cardiovascular problems, diabetes mellitus, chronic lung disease, including asthma, and interestingly, a history of hypertension and recent diagnosis of cancer, those individuals tend also to have a more complicated type of illness. So it's older age plus underlying medical conditions like I just described.
How are we doing in the hospitals? Do we have enough ventilators? The projection and the numbers that we've seen from the governor's office, for example, Do you expect that it's going to reach that level? Or will we be able to taper it off based on how we are all behaving in our community?
I think it really depends where you are in this country, if not throughout the
Yeah.
world. I mean, I think New York, New Jersey, I think are going to be far more pressured than at least my experience here in Santa Monica. I think there are other places that we are clearly concerned about, whether it's going to be Michigan and Chicago. But I think depends on where you are, and it's not a one-size-fits-all type of answer. As I told you at the beginning, I think we're managing this problem very well at the present time. But as you know, we spoke a couple of weeks ago, and our concern back then was, do we have the capacity to treat the large number of patients that were expected to present to hospital emergency rooms, with this very severe infection? And I think that concern that was discussed a month ago or so is really coming to become true.
Hmm. Well, now that we have the overflow, right? We've got the ship down, I believe, in Long Beach, and that what takes other patients, not COVID patients, I'm hearing, but other patients, right, with other issues.
Yeah,
Is
the
that
strategy
correct?
was to get non-COVID patients out of the hospitals, get them on the ship, so then the hospitals can be dedicated to taking care of corona patients. It's very time-consuming taking care of these patients because healthcare workers, we don't want to get exposed, we don't want to get infected. So it's a very labor-intensive type of treatment. So it's hard to, put on all the equipment, the gown, the gloves, the eye protection, the mask. You take care of a patient for 20 or 30 minutes, then you have to take all that off and clean yourself up. And now there's a patient that doesn't have that illness. They're dealing with, say, a bad heart attack. And then now you're going to deal with them, but then you got to get back to the other patient and regown and redress again. So it's probably better to have what we call cleaner patients, meaning non-COVID-19 infected patients, have them out of the hospital. And I think that what's the USS Mercy made a lot of sense to me. Get non-COVID patients out of the hospitals and let the hospitals take care of this more active infection.
Where you're located now, do you have enough supplies? Do you have enough ventilators? Should you get an onslaught of patients with COVID-19? And also, do you have supplies, enough masks and gloves and everything that you need for doctors and nurses?
Right. Well, again, as I told you, I don't speak for either institution, but I do not see a shortage. But again, I think we may be early in this pandemic, locally where I am. I see no shortage of masks and gloves and gowns. There seems to be ample supply. But again, the concern isn't today and tomorrow. It's really where are we going to be 2 or even 3 weeks from now? Because some of the projections, which I'm sure you're familiar with, where we're talking 100,000 up to 240,000 deaths. I mean, there's a lot of other folks that are going to need to be taken care of that don't die, but they're still in the hospital. So it's not really today and tomorrow, but I do think the concern starts becoming more significant 2 or 3 weeks from now if the present trends continue.
And is that because people have it but don't know that they have it? Is that why those numbers are going to spike like that?
I think it's a combination of everything. Clearly, there are people that are infected. They are what we would call subclinical. They don't have any symptoms, no signs, no symptoms. But over the next few days or week, they may become symptomatic. As we've talked about earlier, this virus is highly, highly contagious. And even casual contact with somebody who's infected can result in a new infection to the person nearby. And I think one of the concerns we've always had about this virus is how is it spread? And we've talked about the idea that, sure, if somebody sneezes in your face and coughs in your face, you have a good likelihood of becoming infected. But it's also spread by other ways as well. We've talked about surfaces. There is a virus that can be found several hours later and actually several days later, depending on what surface we're talking about. And then I think a very, very big concern, especially to healthcare workers, is the concept of this virus being aerosolized. You go into a room where a patient with COVID-19 has been being taken care of. That patient's been in that room for several hours or days, and they've been coughing and they've been receiving breathing treatments. When that patient leaves that room, that virus is still present in the air in that room. The virus is attached to particles that people cough and breathe out, and some of the heavier particles will settle faster. The lighter particles may float away, but there's a middle ground where some of these viral infected particles that we all produce, they kind of float in the air for several hours. And one of the big concerns is walking into a room that's been occupied by a corona patient and not knowing it, and then you start breathing in these particles, you're probably going to certainly have a significant risk of coming down with the illness.
Let's talk about some of the vaccine production, also some of the therapies that are out there. What has been looking to be hopeful? And if you had a patient who had the coronavirus, would you then, who was actually more serious, would you then prescribe some of these therapies? And have you?
Sure. Yeah. Well, look. I mean, bottom line, the gold standard, the gold treatment here would be a vaccine, because a vaccine sort of prevents the illness, so you don't have to worry about treatment. I think we're a long time away from getting a FDA licensed vaccine for this virus. I think we're a very long time away from that. At least a year.
But very long means what? A year and a half, 5 months?
I would say at least 12 to 18 months, because the products have to be developed, which they are, but then you have to run the clinical trials. So you have to inoculate the group of individuals that are going to be under study, but then you also have to observe the control group, the people that don't get vaccinated, and you have to observe them for a period of time. It's not like you can observe them for 3 days and come up with an answer. You have to observe them over a significant period of time. I'm sure it's months. And then you look for the difference between, hey, how many people in the control group got infected versus how many people in the treatment vaccinated group got infected. And then you have to look at the difference and see if it's significant, is it meaningful. So all this takes time between the actual development of the product and then rolling it out and having people get vaccinated and then observing them over a period of time and then collecting the data and then coming up with an opinion. It all takes a lot of time. And all I can tell you is look how far into the HIV/AIDS epidemic we are. There's no recognized AIDS vaccine that is preventing people from coming down with that viral illness. So it's more complicated than I think the media and general our politicians would like to present. It's a much more complicated problem. And I think we're probably at a bare minimum 12 to 18 months beyond a recognized FDA-approved vaccine.
So then let's talk about some of the therapies that have been used that some are saying have been successful. Others are saying, no, they haven't. There's no proven data. It's very difficult to know what to believe. What would you like to tell us about those therapies that you believe to have been successful in some patients?
Well, I can tell you with certainty there is no FDA-recognized treatment for the COVID-19 virus right now. But there are certain products that are out there right now that people are using. And clearly, I'm sure everybody has heard about hydroxychloroquine as a potential treatment, either alone or in combination with a common antibiotic called azithromycin. There is some good preliminary data coming out of France where that combination, hydroxychloroquine and azithromycin, showed a benefit as compared to those patients that were not treated with that regimen. Clearly, we have a drug called remdesivir, which is being currently explored in clinical trials at several of the hospitals that I go to. So right now we're in the process of accruing patients to collect data. Just like we talked about, you need to look at the number of patients that get vaccinated and compare them to the patients that didn't get vaccinated. same thing with the remdesivir. You have to treat some people, you don't treat others, and you see if there's a difference in survival and outcome. But remdesivir is an active trial.
Go ahead.
I wouldn't let anybody that I'm taking care of, I wouldn't let anybody die without at least trying hydroxychloroquine with azithromycin. And then there's a whole other class of drug, what are called interleukin-6 inhibitors. When people start coming down with this virus, and we talked about that viral load, and that viral load, instead of coming down, which correlates to improvement and resolving illness, when that viral load stays elevated and people are continuing to get sicker and sicker, you get what's called a cytokine storm, which just means your immune system starts becoming extremely active, becomes very, very aggressive, and then your immune system, instead of protecting yourself, starts becoming an enemy of your body, and it starts attacking your lung tissue, and that's why people start developing that condition called ARDS. So there is a new product that is in trial right now to help block interleukin-6, which hopefully can somehow modify or lessen this cytokine storm that's been described.
And what is that? What is that new product?
Well, the name is called tocilizumab, Tocilizumab, and it's a monoclonal antibody. It's a very high-tech type of product, and again, it's hopefully going to throw a wrench into this whole, acute inflammatory process of which interleukin-6 is a big part of. So if you could maybe stop this inflammatory response from going forward and being more and more active, you could hopefully decrease the development of ARDS and all these other inflammatory-based illnesses.
And this sounds hopeful to me at the very least. I mean, between this, you're all working around the clock to try and find something to give hope, to give, some science behind this awful disease that we've all been sort of came onto our doorstep just a few months ago. What's it like for you, a typical day in the life of Dr. Winters? You said you haven't been seeing a lot of patients with COVID, or you have?
Well, I'm different. I'm a little bit older, and I've been in Santa Monica for 28, going on 29 years, and my practice has been sort of beginning maybe a gentle retirement type of program. So I see lots of patients, but I'm not on the front line that I probably would have been, 5 and 10 years ago. But I can tell you that you look at the news reports of our colleagues back on the East Coast, and it's an entirely different existence. So I've got a very different experience going than what's really happening in many parts of our major cities, especially New York City.
Yeah, well, you're clearly you're out there though, and you know what's going on. So I really do appreciate it. Any parting words that you'd like to say to us? I feel that there's hope because I feel like science is working on therapies to help us. I know that they're working around the clock for the vaccine. Although, to your point, I don't think we're going to see anything at least for a year. And reports out there are all over the place. They found a vaccine. It's like, come on, it's not possible. They have to do the trials, or this particular therapy absolutely without question works. And I think, boy, there are so many different irresponsible reports out there. So that's why I know that you're very careful with the information that you put out there. Any parting words that you'd like to say to people?
Yeah, no, I think that I have every confidence that we will see this viral infection reach a sort of a crescendo. We'll get a handle on it. I'm confident the numbers will eventually start going down. And my last point would be, eventually, I think, if a vaccine doesn't come around in real time, we will ultimately have something called herd immunity, where when a significant number of people in the country have been exposed and recovered, there'll be such a large group of people that have been infected and they have protective antibody that it'll make it far less likely that they'll be able to spread it through the people that haven't been infected yet, because the numbers will be so great of the number that have been infected. There's so few people left now that haven't been infected that you don't have these huge numbers that we're currently seeing now. So ultimately, if a vaccine doesn't come around in 12 months or 18 months, It's clearly the virus isn't going anywhere. I think it will eventually infect a very significant percentage of the American population, if not the world's population, because it's so contagious. Eventually, I think herd immunity, and I don't want to be overly cavalier, but if you get infected and you don't survive, then it's over. Then you can't obviously transmit an illness if you're dead. You do get infected and you survive, you now have protective antibodies. Hopefully you won't get reinfected again. Eventually that'll go through the population of the country, if not the world. And that's the other way that we'll solve this problem if we don't get a vaccine first.
Interesting. Very unpredictable days out there for all of us, Doctor. I appreciate you just sort of lending your expertise to all this, because there's so many questions that we all continue to have. Again, practice the social distancing. I'm sure that you saw, what was going on even in our own community over the weekend with the farmers market. We drove past that farmers market and we saw people literally shoulder to shoulder. I simply couldn't believe it. Come on, people.
I think it's public. I think there's some degree, honestly, of denial. I mean, I think this illness is from my standpoint, is fascinating because it's just not a medical problem anymore. Clearly it's a political issue, it's a societal issue, it's a financial issue. I mean, I think it's taken on so many different forms here, and I think at some degree people live in their own world of denial. And when you have so much press, both from the federal level and the state level, trying to encourage people to stay home, stay away from large groups of people. I think the magic number is 10. Eventually there'll probably be some recommendations to start wearing a mask when you're out in public. I mean, there's a lot of information out there to tell people stop going to parties or stop going to farmers markets, standing shoulder to shoulder with other people. I think if we can distance ourselves from each other for a number of weeks, we could probably slow this inevitable infection down considerably. I think, again, we're all probably going to have a really significant chance of becoming infected over the long term if there is no vaccine. But it'd be good to, as they say, flatten the curve instead of having this very steep rise in the number of cases where they double every 2 or 3 days. If you can draw that out, and maybe it doubles every 7 days, every 2 weeks, because there's fewer and fewer people being, acutely infected. Draw it out. We can handle it. We can handle it in the hospital. We can handle it as physicians and nurses. But I have to tell you, I think there's denial going on.
Before I let you go, what about lots of vitamin C and zinc? I've been reading about that. People are running out now and getting vitamin C, and they're taking their zinc lozenges. I mean, I guess It couldn't hurt, right?
Yeah, I don't think it's going to hurt. I think if you take too much vitamin C, you tend to lose it in your urine. It's what we call a water-soluble vitamin. But there's other studies where they were looking at hydroxychloroquine with the combination of zinc. Again, very speculative whether it's going to be useful or not. There's just lots of different strategies, and I think vitamins and a healthy diet are always good advice. I'm not sure it's going to cure you, but I don't think it's going to hurt you.
Right. People will hear the word zinc or vitamin C. That's all they need to hear. And there's a run to the store to go get it. I mean, people just have to be very careful where they get their information. And listen, I'm just big into the social distancing. And washing my hands day and night. I feel like I'm always washing them. And I've been wrapping a scarf around my nose and mouth. Maybe it doesn't help, but it makes me feel better. So, I'm trying to do my little part. So there you go. Doctor, I really appreciate you coming on again.
So far, so good.
Yeah, so far, so good. I appreciate you always being there for us. So thank you, Dr. Robert Winters, infectious disease specialist, for joining us today on Deborah Kobylt Live. And everybody, you could see our show on Facebook and YouTube. And for those of you who listen to your podcast, you can hear us on iHeartRadio, on Apple Podcasts, on Spreaker, on Spotify, and anywhere else that you get your podcasts, we will be there. So again, thank you to the doctor for taking the time. And everybody else, and we'll see you next time. Bye-bye.